that, Thompson prosthesis most commonly is given to a more elderly patient, where it will be fixed by the placement of a cement also, so that in future it is not required to get pulled. While Austin Moore is a prosthesis which is provided in a young patient, where it could be pulled also after some duration of time, and for that pulling, that eye is provided so that it can be fixed to a hook where you can pull it out. All right, so that is the eye. Now another difference which is clearly visible over here, which you can ask, that this can also be considered to be a difference in between the two, that in the stem of unipolar prosthesis there are no fenestrations in Thompson's, while in the stem of Austin Moore there are presence of fenestrations. But don't make this as a point of distinction in between the two, because non-fenestrated Austin Moore prostheses are also available. So it is only the eye in the collar which is a distinguishing feature in between Austin Moore and Thompson prosthesis. So hopefully everything is clear related to this topic in particular, that is fracture neck of femur and its management. Now if you go back to the x-rays over here, cannulated, the CCS, that means cannulated cortical screws, are placed in variable directions in order to achieve the better stability and immobilization after achieving near perfect reduction for the fracture neck of femur, and just wait with the hope that it will unite. On the other hand, you have performed a hemiarthroplasty using a bipolar prosthesis in this case, and you have performed a bilateral total hip replacement, although the indication was not fracture neck of femur over here, the indication was different. But this is how the total hip arthroplasty can also be performed in case of a patient who is suffering from fracture neck of femur, and you can go with the total hip replacement in neglected or old fracture neck of femur cases. All right, so this is how everything is clear, hopefully, related to this particularly important topic, that is fracture neck of femur. Very, very important, very significant complication related topic, that first you have to talk about the complications, then entirely you have to discuss this particular topic. And these are the parts of the total hip arthroplasty. This is acetabulum shell, this A is acetabulum, already you are aware, this A is acetabulum. Now this is the cup of the acetabulum. All right, this is the insert of the acetabulum, that means it is a rubber insert which is placed in between the acetabular cup and the head of the femur. So this is the head, which is obviously made up of different materials, like it could be a ceramic head, it could be UHME head, it could be head of steel. So based on this, we are having a variable articulation systems also. And this is finally the stem of the prosthesis. This is the proximal femur. All right, so as in total hip arthroplasty, what happens, that both acetabulum as well as head of the femur means there will be a preparation of the acetabulum also with the articulating device, and there will be a preparation of the proximal femur also with the articulating device. That is total hip arthroplasty. Now, just several centimeters below the level of neck of femur, we are having another pattern of the fracture which is intertrochanteric. Now, first of all, try to understand what is the meaning of this term intertrochanteric fractures. As the name indicates, inter means in between the two. So if this is a rough diagrammatic representation of the head of femur, neck of femur, the greater trochanter, lesser trochanter and the acetabulum. So this is the greater trochanter, this is the lesser trochanter, and the fracture in between the two, intertrochanteric, that will be called as intertrochanteric fracture, IT fracture, simple. So first point about the intertrochanteric fracture is what are the possible complications and how these complications are different from the fracture neck of femur. As you know that, if the fracture is happening at this site, it will be having different complication, and just below 2 centimeters below the level of this fracture neck of femur, if the complication is happening, if the fracture is happening at this site, it will be having a different complication. This site is cancellous site of the bone. This site is metaphyseal site of the bone. It will be more vascular. If at all there is a fracture, then the possibility of union will be higher. But if this union is not achieved in the best possible way, that means with a perfect reduction, then it will lead to a complication known by the name of malunion. So complication here with the intertrochanteric fracture will be the malunion. And what happens in intertrochanteric, as you can very clearly see over here, that once there is an intertrochanteric fracture, there will be a proximal migration of the femur, as a result of which there will be a shortening. So malunited IT fractures usually present with the shortening of the complete shortening or the true shortening of the entire limb. and the associated fracture, obviously, like there will be pain, there will be limitation of movement, there will be abnormal gait. All these are going to be the associated findings related to this principal complication, that is malunion. Next comes the classification system. You know, Evans has classified the intertrochanteric fractures into two. Simple. One is a stable kind of the fracture and the other one is unstable kind. So what all you need to remember are the criteria which makes the fracture unstable. That what are unstable type of the intertrochanteric fractures. All right. So point number one, if there is a posteromedial comminution, that means there is a fracture, but if the medial wall and the posterior wall of the affected side is broken into multiple pieces, it will be unstable fracture, having the poor prognostic, relatively poor prognostic outcome. Then the second one is reverse obliquity of the fracture. Now, what do you mean by the term reverse oblique fractures? Just imagine, you know, this is the kind of the fracture which most of the time is an oblique kind of the fracture, but reverse obliquity means if the fracture is happening from the lesser trochanter and is going into the lateral wall of the lower femur, so it will be a reverse oblique kind of the fracture, reverse oblique kind of the pattern. So it will make the fracture, or it will render the fracture line unstable. Then the third one is fracture with subtrochanteric extension. That means if there is an intertrochanteric fracture, but if this fracture is going all the way to involve the subtrochanteric region also, then it will be an unstable kind of a fracture. And finally, if there are two or more than two fracture lines, or there are three or more than three part fracture. So if there are three or more than three part fracture means, imagine if there is a single fracture line, just imagine if there is a single fracture line like this, all right, it is creating two parts beside the fracture. But if there is another fracture line which is creating three parts, all right, so three or more than three parts, if they are created because of these multiple fracture lines in this zone, it will be called as unstable. So this is how Evans has classified the fractures into stable and unstable type. As far as the complications are concerned, malunion is considered to be the most common complication. Now comes the important clinical feature, means how the clinical features which are very closely related to neck of femur also, but how it can be very clearly distinguished, or how the two clinical features are very clearly or easily distinguished. So as far as clinical features are concerned, this is the fracture of elderly. Obviously, elderly are very far commonly affected, and this is the kind of the fracture where males are particularly commonly affected compared to females. You know, if the fracture neck of femur is more common in 60, then IT fracture is more common in 75, 70. That means more elderly patients are likely to be affected by this intertrochanteric IT fractures. Second is attitude of the limb. Now, what we have seen as the attitude in fracture neck of femur, that it was kept in flexion and external rotation, but that external rotation was not all the way up to 90 degree. Here, the attitude most commonly is the abduction, extension, while external rotation, and this external rotation is all the way up to 90 degrees. Complete external rotation of the limb. That means lateral border of the foot will touch the couch. All right, abduction or adduction might be present or not, so you need not to worry too much about this. Yes, extension, the limb would be kept in extension and it will be completely externally rotated. This is how you will identify the IT fracture. Now imagine if I give you one question like 75-year-old male came to casualty lying on couch after getting slipped in the washroom. On examination, his limb was found to be abducted and the lateral border of the foot was touching the couch. What is the most likely pattern of the fracture the patient has sustained? So it is in the intertrochanteric region. All right, this is how you will distinguish in between fracture neck of femur and the IT fractures. As I told you, neck of femur are more common in female, IT fractures are more common in male. Neck of femur as well as IT, both of them are the fractures of elderly, but IT fracture is a fracture of more elderly compared to neck of femur. Then neck of femur presents with non-union as a complication. IT fracture presents with the malunion as a complication. and external rotation of the limb in neck of femur is less than 90, that means 60 to 70, but here there will be a complete external rotation of the limb because it is extracapsular fracture. The entire limb is completely rotated. There is no capsule which is preventing this external rotation of the hip or restricting the external rotation of the limb. So hopefully everything is clear. As far as management is concerned, as I told you, because these fractures tend to unite with the best possible outcome, so fixation is the principal or the primary mode of management. So the treatment is, most of the time, it is closed reduction, internal fixation. Means you need not to open the fracture site, you just reduce it by the placement of the patient on a traction table by maneuvers. After reducing it, you fix it by the internal fixation devices. Now here what we have used is a development, dynamic hip screw along with the cancellous compression screw, CCS, which is considered as an anti-rotation screw. Alright, so fixation is considered to be the mode of management for intertrochanteric fractures. Alright, next comes the subtrochanteric fracture. Now, what we are expecting to be asked for the first time in your question related to this topic, subtrochanteric fracture, is that what is the location where this subtrochanteric fracture can happen? Just try to understand. Imagine this is the head of femur, this is neck, this is greater trochanter, lesser trochanter, and then we have the entire shaft of femur, and these are the medial and the lateral condyles of the femur. Now this zone, which is 5 centimeters below the level of lesser trochanter, this zone which is 5 centimeters below the level of lesser trochanter is known as subtrochanteric zone. Alright, so this is not the fracture shaft of femur. If at all the fracture is happening over here in this zone, it will be called as subtrochanteric fracture. Like, as it is very clearly evident in this X-ray, that here we are witnessing a fracture which is below the level of IT region, but it is above the level of shaft region. So it will be called as subtrochanteric. Why is it not called by the name of fracture shaft of femur? Because the management is slightly different as what we do in fracture shaft of femur. Alright, so these are subtrochanteric fractures which have relatively poorer prognosis based on the nature of the fracture. So the location is within the 5 centimeters, within the 5 centimeters from LT, that means lesser trochanter. As far as the names of the classifications are concerned, it is the Russell-Taylor classification, that is just the name you have to remember, you need not to go into the details, and Seen-Scheimer classification. Although there are other classification systems also like Fielding classification, but you need to remember just the names, or if you don't want to remember itself, you can leave the topic. Like, name of classification is not very important for subtrochanteric. What I am saying is that if at all this question is asked, it will be asked for the first time. They will give you a fracture and then they will give you some options like, is it intertrochanteric, is it subtrochanteric, is it fracture shaft of femur, or is it fracture neck of femur? Likewise, there could be options. And you have to identify that this is the region where if there is a fracture, it will be called as subtrochanteric. Alright, this is what we are expecting. As I told you, the management protocol is different. You know, the treatment is not involving the proximal cortical screw. It is involving the proximal screws which goes all the way into the head of femur. So the treatment is closed reduction or open reduction, and internal fixation by the name of the implant is going to be different, that is PFN, that means proximal femoral nail. Although you need not to go into the details of what the PFN generations are, but at least for this point of time, you just have to understand the implant is slightly different from fracture shaft of femur, and this is why we are expecting this sort of a question for you. Next is the fracture shaft of femur. Now fracture shaft, as the name indicates, is within the shaft region, below the level of subtrochanteric, above the level of condylar, will be called as fracture shaft of femur, somewhere in the middle of the cortex. Now, this fracture shaft of femur is important for two reasons. One, amount of blood loss. You know, fracture shaft of femur can present with a massive blood loss of around 2 to 3 units of blood. 1 unit of blood is 350 ml. Out of 350, 49 ml is preservative. That means effectively 1 unit is 300 ml. 2 unit is 600 ml, 3 unit is 900 ml. That means 500 ml to 1 liter of blood could be lost in an isolated fracture shaft of femur. So there will be a huge amount of blood loss. Every time you see a patient with a fracture shaft of femur, after stabilizing the fracture,